All right, so I think we'll make a start. Welcome everybody. And tēnā koutou katoa, ko Ingarangi te whakapaparangi mai. Ko Barry, Greater Manchester, tēnā whenua tupu, ke Auckland o e noho ana. He Executive Officer o i Gut Cancer Foundation, ko Liam Willis Takawinua, tēnā tātou katoa. So welcome everybody. My name is Liam Willis. I am the Executive Officer for the Gut Cancer Foundation. Been lucky enough to be in this role for around 3.5 years. As you can probably tell, I'm not from New Zealand, although I'm very proud to say for the last 6 months I have been a New Zealand citizen. So it's fantastic to join you all in that regard. Really pleased to welcome so many people to this webinar today, and to those who signed up and will be sending the recording through, welcome to you also. Really important topic. And just before we start, I just wanted to do a wee bit of housekeeping and let you guys know, of course, the webinar is being recorded. We'll send a link to everybody post webinar once we've got that. Briefly, I will do some introductions and then do a brief overview of the Gut Cancer Foundation and what we do. And then we'll get straight into the presentations once we introduce our fantastic speakers for today. And we have the Q&A facility available for you guys as well. And there'll be plenty of time for questions at the end of the webinar. So please do note anything you have down in that section, and we'll make sure we ask our speakers those questions today. So before I get started, I just wanted to let you know a little bit about the Gut Cancer Foundation for those of you that don't know. So we do fund research and clinical trials, and we try and act as a voice for cancers of the digestive system. By digestive system, we're talking about the esophageal cancer, gallbladder, liver, stomach, pancreatic, of course, and bowel cancer, including rectal cancer and anal cancer also. So all the cancers of the digestive system. And we try to provide information and education for patients and whānau going through a cancer journey, and raise awareness of the symptoms and the risk factors to help bring urgent need attention to these cancers, which often go under the radar. So in New Zealand, collectively, cancers of the digestive system are, in fact, the most common cancers in New Zealand, and they make up 22% of all cancer diagnoses. So we're talking about a lot of people that are impacted by these cancers on an annual basis, and we can split them really between the lower GI, which is the bowel and colorectal cancers and anal cancer, and the upper GI cancers, of which pancreatic cancer is the most common. The 2019 Ministry stats had around 723 diagnoses every single year. And just to contextualize this for you, I'm sure many of you are aware of the statistics around pancreatic cancer, but we know that the 5-year survival rate for pancreatic cancer is the lowest of any major cancer in New Zealand at just 12%. And approximately around 10 to 15% of pancreatic cancer patients are caught early enough to undergo surgery, which is at the moment is the only potentially curative option of treatment that we have. So that does leave us 85% of cancer patients, pancreatic cancer patients, that are diagnosed at an advanced stage of their cancer journey. What we know about pancreatic cancer is it's very difficult to diagnose, the symptoms are very difficult to spot, and it's very difficult to treat. So every little advantage we can get when we're looking at fighting pancreatic cancer, treating pancreatic cancer, is absolutely vital in increasing those outcomes and improving the outcomes, whether it be quality of life, life expectancy, or survival rates. And the more we've learned and looked into this issue, the more we understand that diet and nutrition can play a huge role in this, in improving outcomes and improving quality of life for patients, regardless of the stage of cancer that you get diagnosed at. So it's with that in mind that we're really delighted today to introduce our guest speakers. We have Amanda Landers, who is currently a senior clinical lecturer with Otago Medical School in Christchurch. And Amanda loves to teach others about palliative care, is currently leading an Australasian research team, the PERT team, looking at enzyme replacement therapy in pancreatic cancer. And also with Amanda today, we have Helen Brown. Helen currently works as a community dietitian in the Nurse Maud Hospice Palliative Care Service in Christchurch. Prior to this, Helen was a dietitian working in mental health at Hill Morton Hospital in the community. Now, Helen has a particular interest in the care of patients with pancreatic cancer and is involved in research in this area and has presented on pancreatic cancer at conferences nationally, internationally. We're delighted to have Amanda and Helen with us here today. And without any further ado, I will stop sharing my screen and hand over to our lovely guest speakers. Kia ora, Amanda, kia ora, Helen, and welcome. And thank you for doing this with us today.
Kia ora, Liam. Thank you for having us. We're pretty chuffed to have been invited along. We're just going to introduce ourselves.
Tēnā koutou, tēnā koutou, tēnā koutou katoa. No kaitaia aho, ko Helen aho, ko Brown tawhanau. Nē reira, tēnā koutou, tēnā koutou, tēnā koutou katoa.
Tēnā koutou, tēnā koutou, tēnā koutou katoa. No mata aho, ko Landers, te whānau, ko Amanda aho. No reira, tēnā koutou, tēnā koutou, tēnā koutou katoa. Right, so we're just going to share our screen with you. And put it on the big screen there. So we're from the ASPECT research team. We're going to talk to you a little bit more about that later. And really, we want to talk with you today about diet and nutrition in pancreatic cancer. We found over the years that it's such a big part of this particular malignancy and not always talked about enough. And so we've made it our mission to spread the word and some knowledge and education around this area. So this is us, and there's some famous people that you can see along the bottom of that slide that have had pancreatic cancer in the recent past. And I guess they spur us on and inspire us globally to keep improving things for people who have this diagnosis. So the first thing is, where is the pancreas in the body? And pretty easy to not know where it is because it's kind of buried quite deep in the abdomen. So if you're lying on your back, it's basically like a fish-shaped organ lying across your spine underneath your liver and your stomach. And that's why people with pancreatic cancer often get back pain, because that's where it's kind of lying across the spine there. So you can see that it's quite high up in the abdomen itself, and then you've got all your intestines, your guts underneath in a big twist. And so that's where it's kind of sitting. You'll also see from the picture that there's a head, a body, and a tail, so kind of much like a fish. And that becomes important when we think about where the tumour might be for someone with pancreatic cancer. So how does the pancreas work? What does it do in the body? And it has two very important functions. If you have a look at the picture that's opened out, you'll see that there's some like florets or flowerets there. And that's where the pancreas in the head and the body are producing lots of enzymes. And those enzymes help digest our food. They get expelled into the small intestine and help break up the food that you've had. And that's absorption or digestion of your food. The pancreas also has another major function in the body, and that's more towards the tail, and that's to do with how we process sugar in the body. And that's why diabetes is often associated with the pancreas. The pancreas produces the insulin in the body that helps us process our sugars. So it has two very important functions. So let's look at what happens if a cancer grows in the organ itself. And the term pancreatic cancer kind of covers a few different places where the tumour may grow. So you can see from the picture there, there's a piece of bowel, and then the pancreas kind of curved into it with a whole bunch of plumbing going back and forth between the two. And that plumbing is called ducts. And you can get tumour or malignancy growing in any one of those places, and they tend to be grouped under pancreatic cancer as a grouping for statistics and things. So it could be in one of those ducts that you've got a wee tumour, or it could be that it's in some of the plumbing inside the pancreas itself, or it could be in that part of the pancreas we talked about that produces the hormones like insulin for diabetes. So it's sort of important going forward that you have some idea of where your tumour is, and hopefully the doctors have shown you your pictures, or you can even ask whereabouts in that bit of anatomy things have changed for you. So Liam's already showed some statistics. There's just a couple of relevant ones. One is that pancreatic cancer is on the increase in New Zealand, and it is sort of equal between males and females. So it doesn't tend to be in one gender or the other. The other not so great statistic is that across the world, New Zealand's had the smallest improvement in survival times. So if you can look there, Australia's had sort of almost 20% improvement. Unfortunately, New Zealand's sitting around the 5%. And that's why people like Helen and I want to try and get information out and improve knowledge so that people can take care of themselves better and get better outcomes ultimately. So as Liam said, it does have the poorest survival rate of all major cancers in Aotearoa, New Zealand. It's the 5th most common cause of death of the cancers, and it tends to be in the slightly older age group and around the 70s mark, but you can see from the graph that there is a distribution between sort of 50s right up to the 90s. It just seems to be grouped more in that 70s group. So from diagnosis, so you or a family member or a patient has gone in and got the diagnosis, could be from the general practitioner, surgeon in hospital after a presentation there. So a number of people may be talking to you about the diagnosis. And so we want to just have a look at that. So as I said, the tumours can grow in different parts of the pancreas, and you can see there a picture of when it grows in the head and how close it is to the bowel there and the ducts. And remember back to the previous picture, this is where most of the enzymes are produced. So if you do have a tumour in the head of the pancreas, it's likely that your enzyme production has been affected, very likely. The next picture is the tumour in the body of the pancreas. And again, if you remember back to the previous picture, you've got enzyme production and hormonal insulin production. And so you may be having issues with both of those things. And then if it's in the tail, it's less likely to be causing enzyme issues, but it still might be. So it's really important that firstly you find out, and secondly that perhaps you ask about things like enzymes, and we're going to talk more about that. So one of the unique things, or the differences with people who have pancreatic cancer, is that they lose weight quite commonly, quite significant amounts of weight at times. And some of that partly is malabsorption, or being unable to digest your food. And hopefully you can now understand a little bit more about why that might be. So if you have a tumour in the head of your pancreas, it's likely 80 to 90% likely that you are needing enzyme replacement. I'm just going to pass over to Helen now. She's going to talk to you about when you aren't digesting your food well.
Thanks, Amanda. So often when I see patients, I ask them what is their first presentation that they noticed something was wrong. And as Amanda mentioned before, there's, depending on the area that the tumour is, you can present with certain symptoms. Often patients will say to me, the first thing they noticed was they went yellow, or family members picked up they went yellow, and there was no other symptoms that they actually found. So as Liam mentioned before, pancreatic cancer for GPs is not an easy cancer to pick up. And often patients want to know, why did my GP not pick this up? It doesn't throw up warning flags like some of the other cancers. So malabsorption, you can get malabsorption for several reasons, and Amanda's covered off on some of these. If you're in the small percentage of people who can have surgery, or a Whipples, as they call it, then because part of the pancreas or all of the pancreas is being removed, you won't be producing the digestive enzymes. You may have a blockage in the duct that transports the enzymes to the small bowel. And so you're still producing the enzymes, but they can't get to where they need to go. And the pancreatic tumours may be infiltrating the cells that produce the enzymes. So you're not producing the enzymes at all. And the common result from this is steatorrhea or a fatty diarrhea and weight loss. I'd just like to mention that for Amanda and I worked together for a lot of years before she took on the teaching roles more and more. Amanda was a palliative consultant, and the patients we would often see often didn't present with diarrhea. And the reason being that they were often on pain-relieving medications that had a constipating factor, so it masked the symptom of fatty diarrhea. The motion would still be pale and floating, but you wouldn't get the looseness and perhaps urgency. So what sort of symptoms might you get with malabsorption? You might get heartburn. And with this, you may get increase in belching. And you may not typically pick this up, but family members may be aware that you're belching more often than you used to. An increase in flatus, or commonly known farting. And the odour of this is quite distinct. It's undigested food, so it has a very, very strong, different odour to a normal wind odour. You may get cramping or pain after eating, and progressively over the day, as you eat more and more, this discomfort or pain can increase, so that by the end of the day, you don't feel like eating. You don't know where to put yourself because you can't get comfortable. And patients will often say they go to bed and they just can't settle because they're uncomfortable. You may get bloating or tightness. And often when I speak to female patients, it's right on that bra line. And so by the end of the day, they're having to loosen their clothes or loosen their bra or take it off altogether. Or women have said to me they've had to go out and buy new bras because it's too uncomfortable, feeling like they're being cut in half. For men, often they say to me, it feels like somebody's tightening a strap across their chest. So you can imagine that if somebody has a cardiac history, it's easy to confuse those two. And nausea and or vomiting can also be a problem. And as you can imagine, if you're eating food to try and maintain your health, but there's no digestive enzymes to break it down small enough for it to be absorbed through the gut for all to be used, then you're going to lose weight. And if we don't catch these people early, 10 kg weight loss in a short period of time is quite realistic to notice. So what can we do about malabsorption for people with pancreatic cancer? So Amanda mentioned that if you have a tumour in the head of your pancreas, and it's always helpful when I go and see patients if they know where the tumour is. And usually I've had a look on the hospital notes to see where the CT scan shows the tumour. The most common way of replacing human digestive enzymes is through a porcine or pig-based pancreatic enzyme replacement therapy. And one of them is called Creon. There's another called Pancreatic. That's the two most commonly available in New Zealand currently. Generally, I would tend to use Creon 25,000 solely with all my patients. However, some clinicians will give Creon 25,000 for meals and maybe Creon 10,000 for snacks, but I find this confuses patients. Over COVID times, some of our supply chains dried up a little bit, and for some regions around New Zealand, Creon 25,000 went out of stock for a period of time. So Creon 35,000, 40,000 became available. But I still currently use Creon 25,000. So to work out the dosage of the Creon you need is dependent on the fat content of your meal. Now, because we're often dealing with people who are feeling very unwell, very fatigued, we don't expect you to work out how much fat is in a meal to work out how many digestive enzymes you need to take, because by the time you've worked that out, you're so fatigued you don't want to eat the meal. So we start with a baseline dose and then titrate up depending on symptoms. The other important thing to note is that for anybody with a sulfur drug allergy, and luckily there aren't many drugs now that have sulfur in them, Creon actually has sulfur as a byproduct of production. So if you do have a sulfur drug allergy, Creon isn't necessarily going to work for you. But however, Pancreatic, the other digestive enzyme replacement therapy available, doesn't have sulfur in it as a byproduct. So there is an alternative. And if you don't find Pancreatic easy, you can always break down the capsule and put it into as acid food if you do have a sulfur drug allergy, because it's in the capsule that the sulfur is, not in the enzyme beads. Excuse me. Okay, so guidelines for taking enzymes. Enzymes should be taken with every meal and snack. And often what Amanda and I used to see in the old days when we started doing our research was that patients would be prescribed it with meals, but they wouldn't be told to take it with snacks. So they would then become symptomatic in between meals because of the lack of enzyme with the snacks they were taking. So you need to take it with all snacks and meals that contain carbohydrate and protein and fat. There are some foods you don't need to take Creon with, fresh fruit and vegetables, fruit juices, fruit drinks, lemon, lime and bitters, fizzy drinks, things like that. Bovril, anything that really doesn't need a great deal of breaking down and digesting. Now, taking the enzymes, if you're somebody that's still actually eating a reasonably large meal, some of our gentlemen are still eating pretty well, then it helps to actually split dose the Creon. Your peak action time of your Creon is the first half hour. So that's why we say, take it as you sit down to eat, not half an hour before a meal, like you would take your anti-nausea medication. Because if you took it half an hour before, you would lose that peak action time of the enzyme, and the concentration of the enzyme decreases generally over the 2 hours that you digest a meal. So that first half hour is pretty important. So if you eat a big meal and split dose and have 2 at the beginning of the meal and 2 halfway through or at the end of the meal, you drag out that peak action time and get a better bang for your buck from the medication.
I always think of it like a Pac-Man. So you've eaten the enzymes and it has to have something to chomp on. So if you have it too early, the Pac-Man have gone.
Yeah.
Just sort of think about those enzymes as kind of active at the time.
And we want those enzymes and the food to get to the small bowel at the same time. So it's really important that we have it around those meals. It's really important that you don't crush the beads, because if you crush the beads, it exposes the enzymes to the gastric acid in the stomach. And so it destroys the enzymes. So by the time they get to the small intestine, they're useless. They're not going to do you any good at all. And also don't chew the capsules, because it can irritate the oral mucosa. It can irritate the inside of your mouth and make your mouth sore. If somebody struggles with taking capsules, and when we first started talking to patients, we found that often they were never asked if they had problems taking capsules to give them a second strategy of how to take their enzymes. So now I always say to patients, do you have any problems taking medication, taking capsules? And if they do, and some of their residential care facilities staff have rung and asked me before, what can they do? You can break the capsules down, but it's really important that you put it in the right acidity of food to take it. Now, if you think about most of the foods that if patients have problems taking medications, we tell them to put it in with custards, yogurts, sort of those creamy, milky things, then often those foods are a basic environment. And so if you put the beads into those, the outer protective coating on the bead will wear away in a basic environment, exposing the enzymes. So when you swallow those enzymes, they're going to be denatured in the stomach once again. So if you're somebody that has trouble taking the capsules, open them up and put them in an acid-based food, something like pureed fruit, pureed vegetables. Take it down as a spoon of that, and then rinse your mouth out with some water so that you don't leave any residual beads in your mouth that will irritate the oral mucosa. That way, the beads get down into the small intestine before the protective coating wears off, and you'll get the best benefit from the enzymes. Another thing I say to patients is don't have the Creon or Pansy Trap included in your blister packs, because you may snap off a bubble of your blister pack and go out with somebody to a mall or somewhere, and it comes to 12 o'clock when you need to take your pain relief, everything, you take it, and then you go home at 1 o'clock to have your lunch, and the enzymes are well gone. So keep your enzymes out separately so that you can take them as you choose to have meals and snacks. And the other thing I would say is it's really important when you start on Creon to start your laxative regime, because it may have been that you're already on morphine or codeine for a pain reliever, but you haven't needed to take a laxative regime because you're malabsorbing, your bowel motions have been a little bit looser. But once we correct your malabsorption, if you don't start up your laxative regime, you will become constipated, and that'll cause another whole big problem that we have to sort out. So as soon as you start your Creon, start your laxative regime. Now, I often tell my patients what their maximum dose of Creon a day is, and that's because a lot of the medications that our patients are on, they have to be very careful how they increase and decrease doses, or they can go toxic. But with Creon, you can't go toxic. It's a very safe medication. So it's really helpful to know what your maximum dose is. None of my patients ever get to their maximum dose, but it gives them confidence to adjust their dosages without worrying about overdosing themselves. So I always work out for my patients by working out what their weight is, what their maximum dose is, and then they can take control back over of manipulating their dose of Creon depending on what they're eating. A few things to remember about pancreatic enzymes. They have reduced effectiveness with calcium, magnesium containing antacids. That's because the two medications bind together and neither medication is then effective. Omeprazole or pantoprazole, which a lot of people know is prescribed for reflux, is a really good buddy drug for Creon, because what it does is it stops the duodenum, where your absorption happens, the top of the small bowel, from being too acid, because if it's too acid, that protective coating won't wear away from the beads. So we tend to have a lot of our patients on omeprazole or pantoprazole to increase the effectiveness of their Creon. So I say to patients, if anybody's going to rationalize your medications, don't let them rationalize your omeprazole or pantoprazole, because it has a really positive impact on your Creon.
So what Helen's saying, and I think it's called low sec. You may, if you look at your bottle, maybe called low sec, is to remind doctors not to stop it, but because it's working well with your enzymes.
Yeah.
Yeah.
Gives your enzymes a super boost.
Yeah.
Okay. So nutrition in pancreatic cancer. So for anybody who's has got pancreatic cancer, you'll know that it affects your appetite. It's really important that we don't restrict fat. And initially, early on in the piece, when Amanda and I started doing research back in 2010, 2012, we were seeing patients coming out of hospital being told that they are fat intolerant. And in actual fact, they were malabsorbing. And so the treatment they were given was they were told to restrict fat and they would feel better. And some patients who didn't know what was going on would find that when they ate fatty foods, they felt worse, so they would self-restrict. But the problem with doing that is you reduce really good calories, because you're going to be eating less just naturally. You're not going to eat as big a meal as you used to eat. So having fat in that diet is giving you concentrated calories. So for the smaller volume meal, boosting the fat helps increase the calories. Try to eat nourishing meals and snacks. Try to have protein with each meal, and I would suggest trying to eat the protein part of your meal first, so that if you do become full, you've had that protein at least. Make the most of the best time of the day. And I often ask patients, when is your best time? For a lot of patients, it's first thing in the morning because they've had a good rest overnight and they feel revitalized. But for some patients, it takes them a while to get going at the beginning of the day. So maybe lunchtime or tea time is their better time. So it is very individual. You only have so much energy for the day. And so it's really important you choose to use that energy in the most promising way possible to get the nutrition in. So if you spend half an hour, 3/4 of an hour cooking meals, by the time you finish cooking the meal, you have no energy left to eat the meal. So either have other people doing the cooking for you or use ready prepared convenience type foods to your advantage. You can still have a really well-balanced meal using convenience, supermarket ready prepared sauces and things like that. And manipulate your creon dose dependent on the fat content. And I always say to patients, keep an eye on what your bowel motions are looking like, because if they're pale or they're floating or hard to flush, you're probably not taking enough creon. So that's going to be a good judge for you. And if you're getting crampy and belching. Use distractions. So normally for healthy people, we say sit at the table, acknowledge you're having a meal so that your brain picks up you've had a meal. But for somebody with cancer, you don't have an appetite or a great appetite anyway. So sitting in front of a TV, watching the news or having some relaxing music going on or eating with company, that distraction, you'll eat more than you're aware. Now, nutritional supplement drinks. Wherever possible, we try and do food first because it's actually quality of life stuff. But there is a place for nutritional supplement drinks. Now, in the hospital system, we use Ensure powder, which is fully funded, or Fortisip or Ensure Plus, which is partially funded. They're the ready-made ones. But even your up and goes and things are a step in the right direction, or Complans and things like that. Sustagen hospital formula if you don't tolerate the protein and fat content of some of the standard ones.
It's pretty tough if you don't like milky drinks, though, isn't it?
It is. And
yeah.
I always keep some copies of milk-free recipes for people if they don't like milky drinks. The other thing just to keep in mind is that the nutritional companies are working on bringing in vegan alternatives as well. They're produced and available overseas, but they are looking at bringing them in. And I am often asked about plant-based from patients. Up and Go has a non-dairy form, so keep that in mind in the meantime. So if you're somebody that falls into the small percentage of people that are able to have surgery, you will have a Whipples procedure. And this is variable in what they take away, depending on where your tumour is. But it may be a removal of the head of the pancreas. They may take away the duodenum, gallbladder, lower bile duct, and sometimes a portion of the stomach. So it's variable. You may have a distal pancreatectomy where they only take away the tail bit, or it may be they take away the whole part. Or in some circumstances, if they can't remove the tumour, they may do a bypass where they bypass the tumour and bring the bowel round to another area. So I don't see people who are in hospital ready for Whipples because I work solely in the community in the palliative care team. But I know from talking to colleagues who do this role that after having a Whipples procedure, you tend to eat small, frequent meals, drink around meals rather than at meals so that you don't fill up too quickly or dilute your digestive juices. It's really important to monitor your weight and see a dietitian if you're losing weight. And usually with somebody having a Whipples procedure, you'll be under the management of a dietitian in hospital. And hopefully will be discharged to a dietetic care in the community. Initially, with a Whipples, you may be asked to avoid high-fat foods just while the healing of the anastomosis, the joining areas are heals. But after that, and once your creon's brought into the picture and you adjust your creon dose, you can gradually bring fat foods back into the diet. Some patients unfortunately develop what we call dumping syndrome. And it might be because part of the lower part of the stomach's been removed and the valve has been removed, perhaps. So a dumping syndrome is where the food comes into the small intestine too quickly, and you get some quite unpleasant symptoms with that. You get fullness, flushing, sweating, you might get a bit of a racing heart, and diarrhea generally 15 to 30 minutes after eating. And this, as I said, this results from the food going in too quickly. So you want to avoid large meals because that's a big dump on your system in one go. So eating small and often is generally better tolerated by somebody who suffers dumping syndrome. Avoid high sugar foods because that's a very concentrated dump that will go onto your system and draw fluid out of the body. Avoid drinking with meals, as we mentioned before. And with your Creon, perhaps try opening the capsules and putting them in food so that you're doing it a step further for the body, so that you're possibly getting more effect from your Creon. Now, if you go on to have chemotherapy, it's really important that we work on trying to maintain your weight, because often your Creon dose is dose to weight related. So if you suddenly lost 5 or 10 kilos, you may not be able to get the maximum dose of chemotherapy they could previously have offered you. And generally, I say to patients, after 2 or 3 cycles of chemo, you'll get a feel for how you're going to be after each cycle. So it might be that the first couple of days after, you're very fatigued, having afternoon sleeps, you may feel nauseated. So during those times, it might be that we need to tweak things with your diet a little bit to try and manage your weight loss. It might be that you have taste or smell acuity, so that that you're picking up different tastes in foods, and that's very individual. And fatigue is a real problem. If you're nauseated, it might be, if you're on nutritional supplement drinks, just to hold off for a couple of days so you don't put yourself off them permanently, and then come back onto them for the second part of the week to build yourself up before your next chemotherapy. Loss of appetite, eat little and often. And as we've mentioned before, eating the most nourishing part, and try to drink fluids between meals. Make your fluids count, so that have fluids that have got a few more calories in them, and make your eating environment relaxing.
So what about, like in the picture, there was a wine there, Helen?
I would tend to say be led by your healthcare professionals. You may like the idea of having a glass of wine, but actually, once you pour it and take the first sip, the memory is more than the actual doing.
So probably higher calorie drinks.
Yes.
But perhaps not red wine.
Perhaps not red wine, because the other thing is you might be struggling to get sufficient hydration in, and an alcoholic drink will dehydrate as well. So just quickly, if you can, be referred to a dietitian for support if that's available. If it's not available in your area, then you can go on the Dietitians New Zealand website and put into the search and find a dietitian. And there'll be a dietitian within the area somewhere that you can perhaps link up with and get some advice from.
There's the website there.
There's the website, yep.
So you may need to travel for that service, and hopefully it is funded if you do need to travel, or you may need to, find out from your local services what's available.
Sometimes we can actually do a telehealth call as well. If you live very rurally and are too fatigued, we can do a telehealth call so that we can help you over that system as well.
But if you can't access a dietitian in a prompt manner, or you're really struggling, we have a resource that you can use that tells you a little bit about what we've talked about today. Also, unfortunately, we've had a few stories where people have gone to their health practitioners and haven't perhaps had the response that they wanted around enzyme replacement. And so on the screen, you'll see our our patient information pamphlet that is downloadable, and you could take it with you to a health professional if you need it. If you go on to the UTS website, that's actually the University of Technology Sydney. That just happens to be where our website is based. You would be able to search ASPERT. ASPERT stands for Aotearoa Australia Pancreatic Enzyme Replacement Therapy Research Group. And you'll be able to download that pamphlet. There's also some other information on that website. So that's the full name of our group. We aspire to be experts in pancreatic enzyme replacement. We have lots of really good ties with the National Gut Foundation and PECANS, which is the Pancreatic Cancer Aotearoa New Zealand support group. And so we're all working together to try and improve things for New Zealanders with pancreatic cancer. We have a Facebook page, Instagram, LinkedIn, and Twitter. So if you should be able to find us somewhere on one of those platforms. So there's the other support places that I've just mentioned. PECANS has coffee groups where you can actually get together with others in a similar situation. And so, yeah, please reach out if you're wanting more information, particularly around diet and nutrition. So I think that's us, Liam, just waiting to see if there's any questions or comments.
All right, thank you so much, guys. Do you want to unshare your screen so we can
Yes.
jump into a Q&A session?
Sure.
All right, thank you. That was hugely insightful, extremely useful, very practical, and I'm sure of great use to those of us that would join us today and that we will send the link on to afterwards. So thank you so much for your time and expertise. It's hugely appreciated. We do have just one question at the moment. It's a specific one which I'll go to. It was around the conversation around enzyme replacement therapy, and you mentioned pansy tract. Is it? So the questioner in this instance has said they've come across an article from Pharmac saying it's discontinued. Do we know that?
Now, we had a dietitians conference just recently, and there was some discussion that they had heard that it possibly was going to be. So I'm sorry, I haven't caught up with it. It may have been disestablished since. So in that case, in New Zealand, we only have Creon.
And that's a little bit of a problem if you're someone who has a pork allergy or for cultural reasons can't have pork products. So that's just something to bear in mind and that you might need to talk with your dietitian or health professional about. And
certainly for those people with a sulfur drug allergy, with the Creon, open up the capsules because it's the capsule casing that has the sulfur in it. You can still use the beads and put it into your acidic food to take down.
Yeah.
Awesome. Thank you. So guys who are on the webinar, please do ask a question via the Q&A. Feel free. We have 15 minutes of time available here to do so. And Amanda and Helen are here to answer anything that you do have. I guess in the meantime, I'd ask a general question, guys, about what stage in your diagnosis and treatment plan should you expect to receive a referral to a dietitian? So when, you know, if you haven't done, if you come off this call today and you think, actually I haven't had a referral yet, oh, it will happen, I'll hang on. When actually should people be asking the questions and advocating for themselves to do so?
When we started our research in 2010, 2012, we were seeing people 6 months down the track, and it was district nurses that were referring because of weight loss. And that's where we were picking up that these people were malabsorbing. They had been prescribed Creon, but they didn't know why they needed it. They hadn't been educated as to what it did for them. So I would be saying to patients, at diagnosis, they should be asking to be seen by a dietitian, because even if they don't have malabsorption, actually having that bit of a discussion around eating can be really helpful. And it just means that it gives them somebody to contact if they start running into problems further down the track. Yeah,
I mean, it's hard because the initial diagnosis is, you know, it's pretty shocking and you're taking in so much information and processing. So I would just say as early as is practicable for you in your situation.
Even asking your GP, if you're not going back to see the consultants or anything anymore, ask your GP to refer through to a dietitian.
Yeah, that as soon as you practically can. Yeah.
Great, thank you. We've just got one comment mentioning that they're on the recommended site. And of the 10 items shown on Aspert, there isn't any information pamphlet. So if we're struggling to find it at the moment, what we will do is we will send out the links to everybody that's registered for this webinar. We'll send the links to all the information that Amanda and Helen have referred to. And with their permission, of course, we'll probably get it on the GCF website as well and link to it from there. So we'll make sure you guys have all that information in the follow-up email to this webinar.
Yeah, just you are on the website. It says PERT information for people with pancreatic cancer, and then there's 2 links, one for New Zealand and one for Australia. So if you scroll down, it will be there, but Liam will send out the links. Yeah.
It's a really important question here as well from Tara, which is, look, should all pancreatic cancer patients be taking PERT? You know, regardless of where the tumour is, whether they've had Whipples or they are going through chemo, what stage is it appropriate for somebody to be taking enzyme replacement therapy?
We would say all our head of pancreas patients should be on Creon. Body probably pretty close behind. Yeah. Tail is dependent on what symptoms they have. If I have somebody with body of pancreas cancer and I'm not sure, I will organise a fecal elastase test, which is a test that will show whether somebody is malabsorbing or not, but start them on a trial of Creon, because it takes 2 weeks for those fecal elastase tests to come back. So you can lose a lot of weight in 2 weeks. So by starting somebody on Creon, we're not doing them any harm, but we may be preventing them losing a lot more weight. And then if the fecal elastase comes back and shows they're not malabsorbing, we can stop it. But if they are malabsorbing, we've got a head start on keeping the weight on. The other cancer, pancreatic cancer that we used to think didn't need Creon, but I'm finding more and more, there is a group of them now that does, is the neuroendocrine pancreatic cancers. And so usually those patients are treated with octreotide to calm their bowels down. But actually, if they still are symptomatic, some of our cancer nurse coordinators are now referring the neuroendocrines to me as well, and we're starting them on Creon and octreotide, and it's managing their symptoms better.
Yeah, we did like a worldwide search in the literature around the impact of PERT on pancreatic cancer diagnoses, and there was 12 papers in the entire research globally ever. So this is a very misunderstood area with a lot more information needed, or a lot more knowledge. What we do know though is it's well tolerated. So when people know why they're taking it, there's very few side effects because it's just replacing what your body produces anyway. So with that in mind, we tend to start most people on it, to be honest, because you start it. And the other thing is sometimes people don't realize they have these symptoms until you take them away. So they don't notice the bloating, they don't notice that they're more windy or they're belching until you actually treat them and they go, oh, I actually feel quite a lot better, or, oh, I'm able to eat more and feeling less nauseated. So, because they're sort of subtle. So what we're finding is that, as Helen said, we're probably erring on the side of putting most people on it as a trial of therapy. We know it's well tolerated. We know it doesn't have a lot of adverse effects. And then coming back to people and saying, did you get any benefit, particularly with those tail of pancreas people?
I think the other thing is, initially when I first see a patient and ask them about symptoms, they've not necessarily made the tie with food and symptoms. And you'll ask them about their bowels and they don't know what's happening with their bowels because not everybody checks. So once you educate them on what to look for, the second time I go to see them, they are full of information on what's happening. And they can tell you exactly what's happening because they know what to look for. And we had GPs here in Christchurch that have said that they've had patients fronting up to them in clinics who all they want to talk about is their food because that's what's causing the problem. And they don't know why, and the GP doesn't know why. And so it's getting that tie out there that the malabsorption symptoms are huge in patients' lives. It really controls their quality of life. Once you get on top of those, we had one patient say that magic little pill, why didn't somebody give it to me a month ago?
Because in our culture, food is social, food is family, you know, and if you have diarrhea, you don't want to leave the house, or you need to know where toilets are all the time. And so
you won't try and close in a shop in case you get caught out.
Yes. So we found that this, you know, this quite benign medication was making quite a big difference to quality of life for people in all sorts of ways, not just food and eating. Yeah.
The other thing that's coming through a little bit more in the research too is that we can put a patient on Creon and we can follow them up to make sure that things haven't slipped back into old habit of taking it with your antiemetic medication things, and they're doing everything right, and they still have some problem with diarrhea. And there is some research coming through now that a lot of it's in the pancreatitis, because that's an area that's been researched more, but that you can get bacterial overgrowth in the gut from the fact that the bicarbonate that you normally would get in digestive juices that helps keep the gut in a healthy state isn't there. And so bacteria proliferate, you get bacterial overgrowth, you get a bloating and diarrhea from that. And so we've had a few patients that we've started on a short dose of antibiotic to sort out bacterial overgrowth.
So I guess what Helen's saying is it's quite a specialized area. So make sure you get, you know, good help and good advice.
And just a reminder then, if somebody is struggling to get access to a dietitian, there was the Dietitians New Zealand website that they could go to potentially.
And there's a search engine that says find a dietitian, and you can go to your region. Yeah.
And who is it that prescribes PERT generally? Is it the surgeons and oncologists? Is it the dietitians? Where is this prescription coming from?
So that's been part of our latest research. We actually asked people in New Zealand and Australia who was prescribing their PERT and how. And we're just crunching those numbers at the moment. But it looks like it's actually surgeons are top of the list because that's who people with pancreatic cancer tend to see first. And then oncologists would be the other one, cancer doctors. It's pretty hard for general practitioners because they may only see one or two every few years, and they have a large patient population, and they may only have one or two people with pancreatic cancer.
And so, specialist dietitians also prescribe. So I do all my own prescribing for PERT. So I see a patient and educate on malabsorption, what PERT does, prescribe, and then come back in a week and just double check, and then be the contact person.
Well, I guess that was probably the genesis of my question, because it appears that, you know, there's an awful lot of information that you guys have brilliantly put over today. And simply having the treatment, the PERT on its own is not the answer. The answer is having that plus the assistance. So, you know, having the prescription is not necessarily the magic one that having the prescription plus the advice would be. So I guess what I was trying to get at and understand is as a patient going through that journey, if you're just seeing a surgeon and they're prescribing PERT, you know, what would the next steps be? Because it seems that they're not necessarily getting the advice at that point that they would need to be taking it properly. So at that point, they really need to be, if they're not referred already, they need to be seeking out the advice of a dietitian.
I think it's like a two-pronged approach. That's where we've kind of landed with this. We need to educate clinicians better about enzyme replacement and you know, its place in pancreatic cancer treatment, but we actually also need to empower people with pancreatic cancer and their families and the community to actually be asking for it. So that's why, you know, we want to do kind of both at the same time, because if we don't, I think it still could be a rocky road ahead.
I think the other thing is that our surgeons will start patients on PERT just to get them onto it so that they get some relief. They will then, through the cancer nurse coordinators, refer through to our service, and I will pick them up and tweak their Creon more to what they're eating. Because as patients start eating, feel better, they eat more. But if they don't adjust the Creon dose, the symptoms come back. So it's the networking between the hospital and the community of, yes, we'll start it, send it out to you, you do the education, and then give the ownership of the health back to the patient so that they can control it themselves and take ownership back over it themselves. And one of our research papers we did was the patient's perspectives of taking Creon, and their health literacy was really high.
Amazing.
Patients understand if it's explained to them, they understand and they take ownership and they drive it and they enjoy driving it. So that's where we come from.
Yeah.
That's really helpful. Thank you. I guess one final thought from me would be that a lot of what we discussed here and the impact of what you're talking about has been a real improvement on quality of life. The fact people can have food again, they can eat food, they put weight back on. But is there any research or evidence beyond what seems to me relatively intuitive anecdotal evidence that would also improve outcomes when it comes to life expectancy, for example, of somebody with advanced stage pancreatic cancer? Because you've got more weight, you may be able to tolerate your chemotherapy treatment better, etc. I mean, I'm probably taking a bit of a simplistic approach to it there, but do you guys know of any evidence that would back up that kind of thought?
Yeah, so there's two issues with that. One is, Liam, PERT is now written in all international guidelines around the world for pancreatic cancer, despite the fact that globally it's not being prescribed at very high rates. What that means is you can't do a randomized trial where you deny a group of patients access to PERT, which means that we now can't do that sort of big study that will tell us absolutely what the survival benefit is. But there was a very clever group in the UK who looked at this area and matched 400 pairs of patients. One of the pairs didn't have PERT and one of the pair did, and they were matched in other ways like age and gender and everything. And they actually found quite a significant survival benefit, like more than chemotherapy at the time. So that kind of spurred us on. We now can't do the ultimate trial, and neither could anyone else ethically around the world, but there are certainly positive signals that it does confer a survival benefit. And like you say, it kind of makes sense. If you're not losing weight, at a rate of knots, if you're digesting your food, then you're more likely to be able to have treatment. You're more likely to stay well for longer. You're just replacing something that your body can't produce or can't get to the right place. So we think that that's probably likely, but we couldn't put our hand on our heart and say that the study has been done. Yeah.
All right. Well, it's fascinating stuff, and I think it's so informative and helpful. And hopefully the people on the webinar today have got some really useful information that they perhaps didn't know before, and some actions to take from this. So look, we'll send out the recording, as I say, so you can go back over this. You've got all the information at hand, and we'll add in the links that Amanda and Helen have alluded to here, so that you can have access to those further resources as well. Just remains me to say thank you so much to you, Amanda, and to you, Helen, for taking your time, sharing your expertise on this really, really important subject. We will get this webinar distributed and pop it up on our website as well, so that people can have access to it as a resource moving forward. So thank you. We really, really appreciate your time and expertise.
Thank you for inviting us.
It's a pleasure, and thank you everybody for attending. And at this point, we will end the webinar, and we hope to see you on the next time we do one of these. Thank you very much.
Thanks.